I'm an addiction psychiatrist by training, also a researcher here in Montreal. People, and especially people with opioid use disorder treatment, were very hard to follow. When you start, for example, Methadone or Suboxone, having to go to the pharmacy or the clinic every day for the first months of treatment. One of the things we decided to do at this point is how can we make these treatments a little more flexible? And that's where the OPTIMA trial was born.
All right, what's going on, everybody? My name is Daniel Unmanageable. That was today's guest, Dr. Didier Jutras-Aswad. And this is a special CRCHUM Quebec Atlantic production of Hard Knocks Talks, coming at you from Treaty 6 territory, Saskatoon, Saskatchewan, and the traditional homeland, the Métis people. Let's bring in Didier. Hey, Didier, how are you?
I'm good. How are you, Daniel?
I'm doing well. I'm like still a little bit insecure about pronouncing your name right. I hope I did it justice.
Well, let's keep it as Didier. I guess it'll make your job easier.
Okay. So is there anything that you would like to say or acknowledge before we jump into the interview here?
Absolutely. I'm here actually in Montreal. So of course on unceded territory from the Mohawk community. So I'm very happy to be with you together and acknowledge that I'm on this Mohawk territory.
Awesome. Okay, well, let's jump in. So we're here to talk about the OPTIMA trial today. So why don't we start with what the OPTIMA trial is?
Well, the OPTIMA trial was, of course, a clinical study, what we call the clinical study, where we developed interventions and new models of care for opioid use disorder, which we evaluated in over 270 people with opioid use disorder. And what the OPTIMA trial was really an attempt to make the treatment for opioid use disorder, namely buprenorphine, naloxone, kind of in a more flexible treatment for people who live with opioid use disorder. And so really, basically the OPTIMA trial was developed, again, a few years ago now. I mean, we're talking about 5-6 years ago, really in the midst of what we called, and I guess what we still call, the opioid crisis, and also the huge problem we have in this country and elsewhere with overdose. And the OPTIMA trial was, of course, not. We never pretended that the OPTIMA trial was the full solution for these problems, but we thought that working on finding more flexible treatment for opioid use disorder could be part of the solution, and that's really what was the idea behind the OPTIMA trial.
All right. So let's talk a little bit about, now we know what it is. Now let's talk a little bit about why it is. How did this come to be? Tell us about some of the barriers that you were seeing that initiated what happened.
Yeah. So if we all remember a little bit, a few years ago, when we talk about 5-6 years ago, of course we were facing, and we're still facing the same problem, unfortunately, but there was a lot of course, overdose, many of them being related to opioids. We had at the time, I think things are a little better now, but again, maybe we can talk about this today. There's still some challenges, but we also had a problem that people who were living with opioid use disorder had trouble accessing treatment or services or any kind of care that actually they would need. And at the time, of course, the clinical trial network, which is also called CRCHUM, researchers within CRCHUM were thinking about how could we be part of the solution, and how could we try to provide some solution, test them, and to make the situation a little better. Of course, at the time, and we were fully aware, when you're trying to tackle such complex, multifaceted problem, you need complex strategies, and there's no single solution that could really provide all answers, all responses that were required. But we tried to look into what were the different types of problem, and of course, and we maybe we'll talk about that today. That there are clearly some problems in terms of even the regulations, the laws. Again, substance possession and whatnot. There were some problem in terms of the harm reduction services and care that we know are efficient and works, but that were not available. And one of the another challenges that we saw at that time, and actually people living with opioid use disorder have been, talking about this for so long, is how some of the treatment for opioid use disorder are so difficult to initiate and follow. And I'm not talking only about in terms of, having access to care, having access to people who could help you, but also talking about when you have access to these treatment, how difficult it is to follow them because they're so intensive and so demanding. And what I'm referring to is also something that clinicians have been hearing a lot, that people with lived experience have been saying a lot, is that when you're in that state where you need care for opioid use disorder and you're asked, for example, to get methadone or buprenorphine naloxone, to go to the pharmacy or the clinic every day to get your medication for the first few months of treatment, that is incredibly challenging for a lot of people. And so that's where it stems. So we thought at the time was that basically maybe that one of the solutions could be to try to make these treatment more flexible, more accessible, easier to follow, and that ultimately people who would come to the point where they would need and want those treatment would be more flexible for them and more appropriate for them and adequate. So that's where it started. And so we decided to tap a little bit on the fact that buprenorphine naloxone is a medication that in theory could allow for less rigid, strict supervision, that daily supervision I was talking about. And so we developed the OPTIMA trial where what we did is compare the standard methadone treatment where people are supervised and have to go to the pharmacy every day for the first few months of treatment, to a more flexible model of care where actually people could start Suboxone and very quickly into the treatment have access to non-supervised take-home doses, allowing them basically not having to go to the pharmacy every day.
So you mentioned briefly a moment ago about harm reduction strategies that the voices of the lived experience that you were hearing were saying this is what would help us, but they weren't seeing it on the spectrum. Can you tell us just briefly about what some of those strategies are?
Well, again, when we talk about harm reduction, especially for opioid use, there are many nowadays, which is great. There's different types of solution. I mean, the obvious one, there's a lot of intervention that could be done. For example, providing safe material for people who would inject drugs, other type of material that people would need, however they use the substance. We do now, of course, have in some places safe injection facilities where people could inject in a safer environment. Now we're talking about safe supply, for example, providing people with safer substances, and it goes on and on and on. Of course, with also some interventions sometimes which are not necessarily some materials or even locations, but more about, like, for example, providing people with adequate information on strategies to use substances in a safe way. Of course, always in a non-judgmental manner. And again, there are so many of them, but that's what we're talking about. And we know that most of these interventions have been studied. We know that they help. They can prevent a lot of problems. Sometimes they can prevent mortality, for example. But again, in Canada, we're still facing the same problem. These interventions are not available to all who would need them.
Yeah, and you just mentioned a moment ago judgment, and that makes me want to steer towards stigma. And so, speaking of that, what were some challenges that you encountered in trying to initiate this trial? Did you face any stigmatic barriers in trying to find the truth?
Well, I mean, there are many challenges, and then we can talk about the pandemic, because we ended up conducting the trial, and when the pandemic, of course, started. But one of the first challenges we had initiating the trial was actually when you set up such study, what you're doing is that you, of course, you have to work with communities, people with lived experience, of course, clinicians, and what we call sites. So basically, clinics that would be willing to participate in the study, offer the interventions to people who would require them or would need them. And of course, when we started to look, and myself, even in, for example, in Quebec, where I was connecting with some clinics, and we were talking about the trial and about the fact that what we were looking into is allowing people on buprenorphine and Naloxone to have up to a week of take-home doses after just 2 weeks of treatment, and after a month having 2 weeks of take-home doses, right?
And what was it
even
before?
there, I'm sorry.
What was it like? What was it?
Oh, well,
standard
at the time, the standard were really that people would have to go to the pharmacy or clinic every day for the first few months of trial, right? And so when we presented the study to clinicians that could be part of the study, some were actually very reluctant and not comfortable providing take-home doses and prescribing take-home doses. Yeah. So again, and that's interesting, because you were talking about stigma, and I think there was a little bit of course, people are want to do good, and including these clinicians, people usually want to help people, but there's still a lot of stigma around treating and providing care for opioid use disorder. And one of the stigma is that you have to try to control and always strictly supervise, and that these medication can be, used in all kind of ways and whatnot. So that's what we have to face. One big challenge we have to face.
I wonder if we couldn't take a moment here, and I might throw Donna in the frying pan here. Oh, she's looking at me terrified. So, I mean, both Donna and myself have experience with methadone. And there was a big barrier, and Donna was talking to it more than I was, but like going to the pharmacy in the morning and standing in that line and the feeling that you would get. And I'm going to bring Donna on screen right now. Why don't you tell us a little bit about how you felt having to go and stand in that line out in the open where everyone could see you and knew what you were doing?
Incredibly degrading. Unspeakably degrading. And then sorry, I got to take my headphones off. On top of that, there was the issue that, we had a baby. So standing in line with the baby in the stroller, people driving by, staring, it was, you're already feeling not great as a human being to be in this position, but then to be put on display like that, it was so immoralizing.
Did that come to light at all during your studies, Didier?
Yes, and that what you just said, I heard it also. I'm a clinician by training, so I'm still doing not only research but also seeing people that I'm the prescriber and the physician, and I hear that a lot. What I also hear, and I don't know if it sounds familiar or it also represents what you've seen, but there was this idea also that like if there was like something great about going to the pharmacy every day, that it was part of care or whatnot. And sometimes going to the clinic frequently can be helpful if you get help there. But what I've also been hearing a lot is the fact that for some people, when you have to go every day to the pharmacy, sometimes that location is also a place where all kind of stuff happens, right? And that it's not necessarily a positive environment to be there so frequently, right?
That would be my next point on that, and then on top of that, the staff were often sort of, for lack of a better word, likely had been dealing with difficult people, in advance, depending on where you were in the line. So oftentimes the staff were not very pleasant to deal with.
And I think it's interesting that you, if I may, but I think, and we talk about stigma and we talk sometimes about services that are not provided the right way and whatnot. And I think it's still happening in this country a lot, and we have to fix that. I'm always careful when we talk about how, for example, for providers or pharmacists or clinicians, there is stigma, but also these people are put in a situation sometimes where they're not able to provide the care that they're supposed to provide, right? And that's also frustrating. And that's also why I think that having, models of care that may be more flexible, maybe sometimes less demanding, can also have the positive impact of putting clinicians and service providers in a better situation, in a spot where they can do their job properly and probably in a better state of mind, right? So I think it all goes together.
Yeah. So I'm hoping we can talk a little bit about those different strategies and modalities that we're hoping to see in the future. But before we get there, what were the results of the trial?
So what we've seen in the trial. So this is, and again, I'll go into something technical, but it's not that technical. I think what we were trying to show here with the trial was that actually giving Suboxone in a more flexible way, not supervising as closely, and giving people, the ability to just live a kind of more normal life at home and without going to the pharmacy every day. That approach, that more flexible models of care, would not be inferior to closely supervising, for example, methadone treatment. In terms of, for example, the ability of people to decrease their opioid use. That was what we call our main outcome. So the main thing we were looking into, and basically that's what we've shown. So we've shown is that actually the flexible approach with buprenorphine naloxone was as effective as the very closely supervised methadone to help people decrease their opioid use. And actually, when you look at our analysis, like when you go into the details of them, actually we have even some signals that actually buprenorphine was better than methadone. So that was the main one of the main finding of the trial. For a lot of other things, what we've seen is that actually, indeed, for other outcomes, that overall buprenorphine, when we provide it in a flexible way, is no more dangerous, for example, than closely supervising medication like we were doing with methadone. So that's another thing, and basically showing that overall, that I guess you can use more flexible approach and be as effective, right? The other thing that we've seen, and that's also something I think is very interesting, is that the people that we really focused on trying to help were people who were not primarily heroin users. So we really focused on people who were using other type of opioids, namely, for example, fentanyl, dilaudid, or any kind of other. Of course, sometimes we know nowadays that it's sometimes all mixed up together, and few of them are mixed up together. So we were focusing on these, and of course, these are different substances than heroin, right? And an interesting finding also is that actually what we realized is that methadone and Suboxone were possibly not as powerful and effective to decrease opioid use and having people stay on treatment than the older studies that we had, where at the time when we were mostly looking at, and helping people with mostly heroin, who were mostly using heroin. And that's also something we have to take from that trial, is that we have much more potent opioid on the market right now. And I guess a lot of people know that. And it may also mean that we'll have to be also creative and more innovative in our approach and treatment if we want to be as effective in our capacity to help people with that type of opioid use disorder.
So speaking of treatment, what do you think, or what do you hope that these results mean for service providers like prescribers or people with opiate use disorders and their loved ones?
Yeah. Well, I mean, the first thing is, I think in the, however you want to call it, the addiction field or substance use treatment field, I think that, we now have more research, but I still think that a lot of our approaches are not based on data, not based on science, not based on study, sometimes based on stigma. And some of what I'm talking about here is sometimes having quite strict approach to treatment, saying, if you want to be successful in treatment, you have to do things that way, right? And you need that number of sessions. You need to be supervised that way for your treatment, for example. And I think if there's a hope for that trial, is that it will be hopefully a meaningful piece of information, trying to open minds a little bit about the fact that I think we have to reconsider even the treatment that now exists. We have to reconsider how we provide them and how we offer them in a more flexible way, in a more pragmatic way, to make sure that actually we're not relying on, again, on, for example, on stigma on how we provide treatment. And what would that mean for the Optima trial, I think, is how can we maybe be more flexible in the way we approach, for example, buprenorphine naloxone treatment, and being much more flexible in terms of the supervision we have to impose on people who want to start that type of treatment, knowing that actually these treatment can be effective when they're flexible.
So was there any indications in this trial? So was this just a fact-finding mission, or was there any outcomes as far as, recommendations that could be put in place to achieve the flexibility and what it is that you're looking at?
Absolutely. Well, to tell you the truth, that's a little bit why I'm here today, is because, of course, when you do clinical trial like this, and scientists, what the first thing we do is, we write a manuscript, a scientific article, and then we publish usually in, these journals that are often read by, people, other scientists and sometimes clinicians. But I mean, again, I think we're missing the most important point. By doing that, is that, we're doing that so that practices can be informed and change, and we can progress in the way we treat, in this case, substance use disorder. And the only way to do that is to go and move and really try to reach people that could change things and use these information. And I think that the two key groups, in my opinion, that are, really the people that we have to make sure that they know about those results are, of course, people who live with opioid use disorder, so that they know that there are some data showing that, such approaches and such treatment could be provided in a more flexible way. And that's something that they can discuss with their clinician and their providers and physicians. And of course, the other group is clinicians themselves and physicians and people who provide care, so that they know that, such treatment, they can be provided in a more flexible way. I think that those are the two groups that we really have to reach. And if there's any output of the trial that are so important now, is making sure we do that work as a group, as a network, to make sure that the result of these trials are known. And that's all why I'm so happy to be here with you today.
Yeah. Yeah, and hopefully, a lot of the people that this will reach, some of them are the voting public. We try so hard to advocate the government, and very meaningful work that needs to be done, helping the government understand what it is we're trying to achieve. But we live in a democracy, so we need to inform the voters of this new information as well. So having said that, what should people know about flexible models of care?
I would say the first key message is that it's possible, and I know it's basic, but in the addiction field or the substance use treatment field, you know, like me, like we have such a strong, long-lasting history of having treatment being rigid. Number of the programs, that you have to do the way they're designed, with, you have to be there at what time, at a very specific time. You have to do that number of sessions. You have to work all these steps in a very specific way. And that if you don't do that, then either you're kicked out or you're not eligible, and it applies to all kinds of treatment, right? Medication, but also other form of non-pharmacological treatment we have in the field. And I think that, such approaches sometimes can help people, but there's a lot of people that would not fit these boxes, right? And these very rigid way of doing things. And I think the first thing, if there's any take-home message from all that work, hopefully, is that actually we can think outside the box, and that when we implement such rigid rules of how to do things, they have to be evidence-based. They have to be based not on stigma, on old habits of doing things, but they have to be based on data showing that that's the best way to help people. So that's for me the key message about flexible models of care. And then, of course, when you look at the very specific data from Optima, what we're looking into is a little bit what I briefly mentioned earlier, is the fact that when you're initiating, for example, buprenorphine naloxone, this idea that everyone has for 3 months to go to the pharmacy every day before being able to have some what we call take-home doses, where people can take the medication at
carries.
home.
Call them
Carries. Exactly. That actually some data are showing that there's possibly no need for that for many people. right? So that's another key part, and that should be discussed when someone is starting a treatment for opioid use disorder. I think that piece of information should be discussed with the clinicians, with for the person who's seeking treatment, so that basically the decision about, what's the level of supervision that is needed for that buprenorphine, how often should I go to the pharmacy, what's good for me, that it can be based on an open dialogue and an open discussion on the actual need of the person, and not necessarily on a priori kind of rules that are not necessarily based on evidence. And flexible means it could be anything, right? There's some people, and I put back my hat as a clinician. I do have some people in treatment who say, I want to go to the clinic or the pharmacy every day at first. Yeah. I need that structure. It's helping me for whatever reason, and that's fine. But you have other people that would say, I'm working 2-3 days a week, and if I miss work, then it's not helping me at all, and I need that flexibility for me on my path, right? And I think we have to be able to hear that and find kind of common ground on what's best for that person.
So looking back, outside of the stigma and the barriers that we've already discussed, what are some other ways that might prevent people from getting take-homes or being prescribed take-home doses?
Well, I think that there are, I think in Canada, we have seen over the last few years an increase in the number of prescribers, and in this country it's mainly physicians, who are better and well-trained in helping people with substance use disorder in a respectful way and based on science and evidence. But I do still think that there are major gaps in terms of our capacity as a society to offer that type of treatment by people who are sufficiently trained and having the right evidence-based approach, And I think if there's one challenge is making sure that's not the case yet, that we have the clinicians that are sufficiently trained, that are aware of that, that type of data, but other type of scientific data to guide their practice and provide the best treatment possible in a flexible way. So I think that's one of the major challenge we have, having people to provide care that are actually trained enough and comfortable providing care in the most effective and flexible way.
So I think that gives us a pretty good idea of what you would like to see in the future. I'm curious though, what are some situations, if there are any, that would continue to prevent people from getting the carry home offered to them?
Well, there are, multiple level to that. Some of the way you prescribe medication, there are some rules around that. So you cannot, and for example, when you're a clinician, there are some guidelines that kind of say, how are you supposed to prescribe that type of medication, what type of treatment you're supposed to provide. So, and it applies to Canada, but elsewhere, I think in Canada, we have the chance to have, some guidelines, especially around opioid use disorder, that are modern in their approach, more open-minded. But I think that in a lot of jurisdiction, it's not the case. A lot of countries where still, guidelines and how physicians, for example, are trained, but also all these guidelines and documents that would tell them how to practice are not allowing for such flexible approach. So I think that's one of the challenges we have to address. One of the challenges actually is, I think that there are probably a good number of people, even people who are living with an opioid use disorder seeking treatment, that don't know that some such flexible approach exists, and that they would just ask for some time or seek some kind of treatment, with this idea and expectation that it cannot be more flexible. So that's why also we have to make sure that people are aware of that. Yeah.
So what's the priority? What is the first thing that needs to happen right now? If we're talking about the mechanics of things to come, what needs to happen now?
Well, we have, as we, discuss together a little bit, I think we have to make these results known. That's what we're doing right now as a team and the CRCHUM network. I mean, today, for example, but there are many other initiatives to make sure that clinicians, that people with live experience, people with opioid users, or that would seek treatment are aware of these results. Also, other stakeholders, people who are policymakers, for example, that will be informed of that. There is some work actually done, for example, in Canada, kind of updating a little bit the guidelines for opioid use disorders. So I think these guidelines in Canada were published a few years ago will be updated, which is, I think, a great thing, because again, when you update these guidelines, you're able to integrate the new practices, the new data, and whatnot. So that really also will be very helpful to make sure that people can have access to that type of intervention. All that being said, all that being said, I also think that we are still facing major problem, right? In our country, with still people, overdosing, dying every day of substance use for all kind of reasons. So I think that these other solutions we were talking about, I think that we also have to work on them and make sure that these things also happen, whether it's, potentially regulations, how we treat and how we consider people who are using substances, what happened to them, being able to provide the full array of, like, the full spectrum of harm reduction services. All these things are still lacking in this country, and we have to work harder to make them happen.
Got a comment coming in here from Chrissy. Chrissy, thank you so much for the comment. Chrissy says, we need long-term treatment centers that provide multiple programs that help change and create behaviors and patterns that are keeping alcoholics and addicts from creating the life they deserve. Healing the inner child by reparenting the inner child. Reparenting the inner child. I like that. Have you heard that before?
Not in those words, but I think I'm not sure exactly what Chrissy. I mean, of course, I don't know Chrissy, but I can see a little bit what she's talking about. I like this approach, and I think that the first thing, I think early in the comment, was we kind of longer term treatment, and we also need like treatment where there would be a diversity of programs, and I think that's, again, goes along what we've been talking about. Nobody's the same. Nobody have the same need, and someone, even the same person along his path, would need some different things, right, in terms of treatment, but in terms of other things than treatment. And I think that in terms of the care we're able to offer and services we're able to offer as a society, we have to make sure that we can match that diversity of needs between people, between different person, but also for the same person that would need different things along their path. So I really like this approach of more flexible programs, and not only about the modalities, like I talked about carries or take-home doses or whatnot, but also about the type of intervention we can offer. And again, moving away from what we've seen a whole lot in this field, which is basically very specific, narrow approach and program where the person has to fit within that approach, and if not, then they have to go elsewhere, and move towards more of an approach where I think we can offer varied things and varied approach, diverse strategies for that person, so that we can match their needs along their path.
We've got a question coming in from Cheryl. Cheryl, thanks for the question. Before we get into the question, though, was there any subjects in your trial that were youth that were coming out of the child welfare system?
That's an excellent question. Not specifically. We're still in, we were quite advanced in looking at, the data we collected and the experience or whatnot, but we're not done yet. So there may be few things that will come out of that. We also had, and I think that's interesting, two fantastic researchers, Lindsay Richardson and N.K. Jaffe, who worked with us. and looking into, not necessarily, because, when we do such study, we collect data, which we call quantitative. So basically we got numbers, right? About things, about opioid use, about retention, about in treatment, about, craving, mental health and whatnot. But Lindsay and Kate were able to collect information from both people who participate in the trial, but also people who were, team members, research staff and whatnot about the trial. And I think that work will be incredibly rich in our ability to understand a little bit better what was the experience of people who did the trial, who experienced having a more flexible model of care, what it meant for them, and maybe the type of question you ask, maybe having some information about that type of topic where sometimes you cannot really catch that with the numbers, but when you hear people, you hear what they have to say. Sometimes that type of things will come up and give another kind of perspective on what was it for this person to participate in such trial and benefit from more flexible treatment approaches.
Yeah, Cheryl was asking if there was any statistics in youth coming out of government care, so that's why I asked.
Yeah, not that I can talk about today, but again, maybe this other work that we'll do maybe provide another kind of way to look at things and understanding a little bit where these people were coming from and what it meant for them to be part of that study and benefiting from those treatments.
So we may have already touched on this, but I want to make sure that we're really thorough. In the future of OUD care, what obstacles do you see and what opportunities do you see?
I think we have, both come together. I think we, in the last few years, of course, in the OPTIMA trial, we were looking at Methadone, Buprenorphine, Naloxone, but nowadays we have other interventions, right? For example, long-acting Circadian, for example, that's another medication that we can use now. And now we started to look into, for example, safe supply using other types of opioids that are regulated and safer and whatnot. And I think we have the opportunity here to look into different type of approaches, not only different type of medication, but different ways and philosophy behind how we provide these medication, right? So I think that's a fantastic opportunity because we're much more. I think we came, at least in Canada, we came to a point where I think we're more flexible as a society in terms of how we approach the treatment of opioid use disorder. But I think the challenge is really to make sure that we have information and evidence and data to really know what works and what doesn't work. And usually it's not necessarily what works and what doesn't work, but in which context an intervention can work and maybe for who it can work. And sometimes when it's maybe not the best intervention, right?
And why it could work.
Exactly. And I think that's the big challenge, is making sure we have the information so that we can guide how we provide these interventions, how people with opioid use disorder can actually decide which intervention they want based on science, not necessarily based on old habits of providing treatment, not based on stigma or whatnot. I think that's the big challenge. I would say the other challenge I think that we have is that I think the landscape of opioid use, if I may say something like that, really changed over the last few years and the last decades. And of course, the opioids that were used like 10, 15 years ago are not the same than the one that are used these days. And the market is not the same. The safety of products is probably not the same. And so we also have to adjust and quickly we provide treatment and not purely relying on, for example, the science that was done like 20 years ago, because we're facing a different situation, a different context, different problems. So I think we have to be very proactive about that.
Okay, so what's next for you?
Well, many things, but work-wise, these days we're, of course, the research team and the CRCHUM network, we're working very hard, and as I mentioned, to make sure that we share the results of the trial, and some people are working on updating, for example, the guidelines for opioid use disorder. So there are many things that are done these days. There is also another very, I think, very exciting and challenging endeavor that we're starting now, and that I'm leading with other colleagues within the network, is to work a little bit and work a lot on actually methamphetamine use disorder. So of course the OPTIMA was for opioid use disorder, but we recently got funding from the Canadian Institute on Health Research to start a trial looking at new interventions for methamphetamine use disorder. Mm-hmm. So we're really in the early phase of that trial, but again, trying and working closely with people with living experience, actually providing tremendously helpful feedback on what type of intervention we should test, how we should test it, what are the most salient, what we should be looking in terms of results and outcomes and whatnot. So we're working on this right now, so that we can start in the next year, actually another trial for methamphetamine use disorder, a pan-Canadian trial across the country. Hopefully, again, bringing in probably 3 years from now, maybe 3 years from now, new data that would help to guide practices, but this time for methamphetamine use disorder, knowing that, if we were talking about the fact that we have challenges in terms of treatment for opioid use disorder, when we talk about methamphetamine use disorder, we have, incredible challenges because we don't have much and many interventions to provide. So that's kind of another big challenge that is coming. I'm very excited, but having a lot of pressure too, because I think we have to do better and quick. So that's the next thing. On my
so
plate.
we'll be seeing you again in 3 years to bring awareness to your findings.
Hopefully, and maybe even before that. Who knows?
We'll be here. We ain't going nowhere. We're actually, I'd just like to thank you for reaching out to us initially, for seeing us as a platform that could bring meaningful awareness to what you're doing. So thank you for that. We appreciate that. Where can people learn more? Like, do you have a website that people can look closer at your findings, or is there any resource centers?
Yeah, so the best way is to look on the CRCHUM website. So there's one, it's CRISM. So on that, if you type CRCHUM, you'll quickly see the website, and their website, the national website, where you can find results. And there's also what we call notes. So each region of Canada now have a kind of a CRCHUM regional platform, where you can also find information and whatnot about the trial and other things that are most relevant to wherever you live in Canada. So that's a good option for that.
Cool. Donna, anything else?
The only thing I was kind of hoping we could sort of dial back on is just sort of a clarification as to the differences between methadone, buprenorphine, Cadian. As briefly as you possibly can.
Yeah, you have 20 seconds. Go.
That's a pretty large umbrella, but just sort of like, I think one is injectable, other ones you have to drink, like just some sort of clarity for people who may not be familiar with.
Yeah, so basically all of them are categorized in the opioid category. So they're basically targeting the same, receptors in the brain that all kind of opioids like heroin, Dilaudid, or whatnot. But they have some very specific differences. For example, methadone, indeed, usually you will drink it. It's mixed with whatever liquid, juice, or whatnot that you will drink. It's a full opioid agonist, which means it's kind of a relatively powerful opioid agonist, but it's long lasting. So you take it usually once a day, sometimes a few times a day. Buprenorphine is a partial agonist. So basically what it means, it's a little less potent. So there's kind of a limit to the extent at which it can really target the receptors in your brain. And that's also why it's considered as safer. So basically, even if you take relatively large amount of buprenorphine, it's very difficult to overdose on buprenorphine alone. And Cadian is kind of a long-acting opioid that is also used for pain, that you can also take usually once daily. It's a longer acting, and the goal here, of course, all these opioids are safer than usually what you can have access to outside of treatment. That's more than 20 seconds, but
no, perfect.
Thank you very much for the clarification.
Okay, that's all we got for you. Is there anything that you'd like to leave us with today?
Well, Thank you for having me. Thanks for everyone that was there today listening or will listen to that for your interest in that topic. I think there's so much more to do, but I think that the best way to do it is to do it together, just like what we've done today. Talk about it, share different perspectives, and of course, always with the people for whom we're doing all that, which is, who are people with lived experience and people who, for example, in this case, who live with opioid use disorder. That's the best way to do things, share ideas and trying to do better as a society. So thanks for having me. That's
Awesome.
much appreciated.
All right. That's it. We'll let you go. Take care, my friend. Best luck in the travels.
Thank you. Bye-bye.
Okay, and that's it for us as well. If you like what we do here, if you want to find more of our content, listen to our audios, you can shop our store, you can get on our email list, go to www.hardknockstalks.com. And that's it for now.